Before performing oral tracheal intubation, you need to make sure you have all your equipment available and ready. The acronym SLOPES has been used often as a memory jogger to make sure that you don't forget anything. S-L-O-P-E-S. S can stand for suction, L stands for your laryngoscope, O stands for oxygen, P stands for your pillow for positioning as well as for your protective personal equipment, E stands for your endotracheal tube, and the S can stand for a number of things, your stylet, your syringe, and your stethoscope. Right. For direct laryngoscopy, we want to visualize our landmarks. We can see the uvula at the top of the mouth there. Now we're going to advance the blade while controlling the tongue and keeping the tongue sweeping it to the right side of the mouth. And we want to advance the blade until we see the epiglottis, which we see there. And we want our blade just on top of the epiglottis, and then we want to do a pull away and upwards from us until we expose the glottic opening. We can see the bottom of the arytenoid cartilage, and we can see a view of the glottic opening there. With some laryngeal manipulation, if we push the larynx down, if an assistant can help us, we can get an even superior view of the cords. And there we have a nice view there of the glottic opening. Now we're ready to advance our tube. So advance the tube through the right side of the mouth and try to visualize the tube passing by the vocal cords. Once the tube has been successfully placed, we need to remove the stylet, ideally so that the tip of the stylet never passes through the cords. So you move the tube off of the stylet, which means you need an extra set of hands to help you. Next, we inflate the cuff, checking that we have a firm little blue pilot cuff, and but it shouldn't be rock hard. Next thing we should do is check for the placement of our tube. So obviously we're going to look for chest rise and fall, and on a mannequin without skin, of course, it's easy to see, but on a real patient we'd see chest rise and fall, and we would auscultate, listening for an absence of breath sounds over the gut or the epigastrum, and positive air sounds in all lung fields. A proper depth of insertion of an endotracheal tube would be, for the average male adult, 23 centimeters at the gums or the teeth. Next, we want to secure the tube, and in this case we're using a Thomas tube restraint. And so we use the tube restraint to squeeze the endotracheal tube in place. Of course, not so hard that we occlude the tube. And then we use the strap that goes around the patient's back of the neck, and it velcros onto itself, so you can get it in place. The only thing we could add onto this is an end-tidal CO2 device, so we could get a numeric value and a qualitative value of our presence of carbon dioxide returning from the lungs.